So thank you, Professor Groschel, for this presentation, and thank you for the organizers to inviting me and to give the opportunity to present the situation we have in Germany and focus on how outcome studies improve newborn screening programs. So in Germany, like in many other European countries, newborn screening has been started with the seminal work of Robert Guthrie and Horst Bickel, which allowed to early diagnose and treat individuals with phenylketonuria. After 15 years now, the newborn screening program has been extended, including now 19 different diseases. As said, I would like to focus on the importance of observational studies in order to address the most important question of newborn screening program, and that is whether they really have an impact on the health of affected and early screened individuals in the long run. In order to address this, we have started long-term observational studies in Southwest Germany more than 20 years ago. And in this area, we cover about 20% of screened newborns. And in recent years, we have extended this to establish national cohorts for single inherited metabolic diseases. By doing so, we now include more than 90% of screened individuals. Looking from the eagle perspective, we can say that newborn screening really resulted in an excellent neurocognitive development and outcome of these children, as you can see from the tests that we have done in a structured way. And it also allowed these children, the majority of them, to attend regular kindergarten and regular primary school. However, if you dig deeper, you can see that what I've said is not true in the same way for every disease and every individual, because for inherited metabolic diseases, some of these diseases are so severe that they already present with symptoms before newborn screening results are available. And so therefore, newborn screening programs cannot prevent acute and mostly neonatal disease manifestation in all of these diseases, as you can see here. However, what we've also learned from these studies is that although some of these have acute disease manifestations, this will not necessarily result in permanent disease manifestation, because not after every of these acute events, these individuals suffer from irreversible organ dysfunction. So therefore, the majority of early screened and treated individuals remain asymptomatic until adolescence or even adulthood. However, you see that there are diseases which have a less optimal outcome after newborn screening because they develop neurologic symptoms. Some of these diseases is glutaric aciduria type 1, where children may develop striatal injury if inadequately treated. We could show that with the prescription of an adherence to recommended therapy, the majority of these individuals still have an optimal outcome and remain asymptomatic. That means we've highlighted here that therapeutic quality becomes the major predictor of outcome in a screening cohort. Another aspect we have learned from these studies is that the case mixes of individuals of newborn screening and pre-newborn screening cohorts often differ. And this is important in terms of case definition, risk stratification, and based on this therapeutic indication. And finally, also the correct evaluation of newborn screening programs. One example I provide here is isovaleric aciduria, where we have in the blue area, individuals with a severe phenotype, and in red, it's depicted a mild disease variant group, which is quite prevalent in Germany. As you can see, both groups differ in terms of the frequency of metabolic decompensations, but also in terms of neurocognitive development. So if you would put both groups together and would not differentiate them, you would overestimate the result of newborn screening program in Germany for this disease. Certainly, you can also imagine that there is ongoing discussion about to what extent individuals with a mild IVA disease variant require treatment in order to avoid overtreatment. So let's come to my conclusion. By doing these studies, we've learned a lot of lessons which can guide newborn screening strategy. We've learned that newborn screening is the prerequisite of favorable clinical outcome, but in order to achieve this goal, we have to address a lot of different aspects like optimal diagnostic process quality, safe and effective therapies, and evidence-based clinical care guidelines. So what we have achieved on a national level, can we also achieve on a European level in order to optimize and continuously improve newborn screening programs on a European level? For this, we require transnational collaborative collection of outcome data and comparative data analysis. Thirdly, such an effort would require some funding and some support in order to achieve this goal for the sake of the patients and for the sake of improving newborn screening on a European level. I thank all my collaborators on a national and European level who have supported these studies for many, many years, and without them, it would have been impossible. And I would like to thank you for your attention. And now I pass on the word to Professor Zetterström from Sweden. Thank you.